Wow. So you're in there and you're making sure, Dr. Stowe, that this patient, that you have the undivided attention guarded toward this one small individual.
That is correct. And I'd like to elaborate on Dr. Evak's point. Our job starts way before we enter the operating room with the patient. One of our, primary goals is to make sure that things are as safe as possible for the child. And as Dr. Evak already mentioned, oftentimes for elective surgery, we'll get to meet the patient and their family ahead of time and perform a complete, medical exam, learning about their medical history, so on and so forth, what medications they're taking, previous reactions with anesthesia, and really preparing them so they're as safe as possible during the surgery. And then, of course, we take them into the operating room and perform the anesthetic and make sure things go as smoothly as possible, as safely as possible, and they're comfortable when they emerge, wake up, and head to the recovery room.
Wow. Now, see, that would make me feel so much better as an uncle or a father, knowing that that research has taken place. How much in advance? Are we talking about 2 hours, 2 days, what?
It depends. I mean, for some patients who have complicated medical history, we would certainly like to see them ahead of time to get the information and make sure that everything is settled before the day of surgery. But some patients who are healthy, who don't have other medical conditions, it's a simple outpatient surgery, we may see them shortly before the procedure.
Okay. Well, I'm glad you cleared that up. We have a couple of very interesting roll-ins, video of a child who's about to be put to sleep. And we're going to go ahead and roll the very first one now. And this shows perhaps a nurse or a doctor who's helping this child understand what's about to happen. And Dr. Holway, I'm going to let you explain. They're blowing bubbles here.
This patient is a young girl, and she has a condition known as Sturge-Weber, which is a port wine stain on her body, and she's had laser procedures to try and lighten the stain over the last couple of months. The woman there is one of the child life specialists, and she has her training in child development, and she's kind of introducing some of the equipment in an age-appropriate way to the child so that it's not so threatening later when we go back to the operating room. And we, all of us, do try to approach children at whatever developmental level they are and try to make, some of this much less frightening.
Wow, and that was very powerful to see the child pick that up. And I think you have one here in the studio, Dr. Stowe, correct?
Yep.
This is a mask, and this is what the child, if you'll pick that up for us, this is what the child would actually have right before that child is unconscious?
Correct. One of the most common ways to induce anesthesia in a child under the age of 10 is to give them a preoperative medication orally to sedate them before they come back to the operating room, and then they're put to sleep with gas through an anesthesia mask that you can see here. It's very soft and plastic, and this one is actually, if you smell it, flavored like bubble gum.
It even looks like bubble gum.
Exactly. So it makes it a lot more comfortable for them to go to sleep. They breathe. This anesthetic mask is attached to this tubing here, as you can see, and the tubing is at the end here is attached to our anesthesia machine.
Oh, I see.
And we breathe in first a little nitrous oxide, which is laughing gas, which some people may be familiar with from going to the dentist, and then breathe in some more potent anesthetic vapors, all related distantly to ether, and they've fallen off to sleep by breathing this gas in and become unconscious. And after that, as Dr. Evak mentioned earlier, we then put in an intravenous. So everything that we do in the operating room that's painfully stimulating is done once they're completely unconscious. So it's simply a matter of breathing some gas through the anesthesia face mask. Takes anywhere from 8, 12, sometimes 15 breaths, and they just pleasantly breathe themselves to sleep. Not very stimulating at all. And once they're unconscious, then the intravenous is placed, and then usually a breathing tube is placed after that to assist them with their breathing during the surgery.
Now, the video clip we just saw, and I don't know if that was just for the camera or if that was a real case, maybe you can tell me, but had that child already gone through the preoperative sedation at that point?
At that point, she had not received any preoperative medications, but it's difficult for a child that age to leave their parents and come with strangers, and that's why we will give them a medication. And as Dr. Evac was saying, in a child that age that will drink out of a cup or syringe, that medication can be given by mouth, and they can drink it. In a young infant, we may just use some nose drops. If somebody has an IV in place, we would use their IV. So it can be administered a lot of different ways, but it makes it easier for the child to come back to the operating room and then to have the equipment introduced.
Was that actually in the OR?
That's actually outside the OR in the preoperative holding area.
Okay.
But as Dr. Stowe was saying, the mask smells like bubble gum. The anesthetic gases, they have an odor. So children would know they're breathing them, but they don't hurt at all. So as they breathe them, we will tell them a story or kind of, maybe sing a song or try to help them with that, and they will gently fall off to sleep.
Did you say that was a nurse in the VO clip?
It's actually one of the child life specialists. She's not a nurse, but
okay.
She has her...
I'm glad you used the term, child life specialist. What is that?
It's an individual who has their training in child development. They work in the hospital. They work with families and patients to prepare them for all sorts of medical procedures, but they also help us in the operating room to prepare the children, and they provide, age-appropriate, language. They help families and with play therapy that's appropriate for the kids, just to allow the kids to be more like children in the hospital and help the families function in the hospital. All of us try to do that as professionals working there.
We are so excited here in the Charlotte region to have the Levine Children's Hospital right here in Charlotte that will be serving the Carolinas. It's going to be the largest children's hospital between DC and Atlanta, and you will be practicing in this hospital, correct?
Yes. And
wow.
it is a great accomplishment for the community. I mean, it took the coordinated effort of a lot of people to bring this to fruition. The hospital administration, business leaders, community leaders, medical professionals. So it is a terrific facility, provides state-of-the-art care.
I got to take a tour of it not too long ago for Media Day, as a matter of fact, and Rick Hendrick and the Levines were there, and it was it's really something. So congratulations on being part of that team.